screen visible?
Yeah, Kalpita,
Yeah,
visible.
yeah.
Sure. So, firstly, good evening, everyone. Thank you so much for giving your precious time on a Saturday evening. And we are very delighted, Team Genova, to have all of you on board for this national level workshop, No Thrombosis. So, I'll start with introducing our esteemed panelists for today. We have Dr. Joseph Sebastian as the course director. Sir is a senior consultant in the Department of Neurology and the head of department at Caritas Neurosciences. Sir has more than 13 years of experience in neurology, neurocritical care, and acute stroke management. He has been internationally trained in stroke care, University of Alberta, Canada, and also neurocritical care from the University of Toronto in Canada. Sir has an expertise in acute stroke management, mechanical thrombectomy, and also complex neurological emergencies. Sir has shown special interest in epilepsy, Parkinson's disease, dementia, and also headache disorders. With extensive experience in managing acute neurological and neurocritical care patients, Sir has also played a key role in developing Caritas Neurosciences as a leading neuroscience center in central Travancore and currently serves as the head of department. Thank you so much, sir, for your valuable time, and we look forward to a lot of insights shared by you. Next on board, we have Dr. Narayan as the moderator with us. Sir is a consultant neurologist and the head of neurology services at the Daya Hospital, Thrissur. Sir has completed his DM Neurology from Bombay Hospital Institute of Medical Sciences, Mumbai, MD General Medicine from the Rajendra Institute of Medical Sciences, Ranchi. Sir has an extensive experience as a consultant neurologist and head of services across leading hospitals, including Daya Hospital, Palakkad Cooperative Hospital and Research Center, and also Saroja Nursing Home. Sir has expertise in diagnosis and management of complex neurological disorders, neuroimaging interpretation, patient counseling, and long-term neurological care. With active visiting consultant across multiple healthcare and community centers, including MOSC Hospital and Sri Satya Sai Primary Healthcare. Sir has also been a recipient of the Best Paper Award at the Bombay Hospital Research Meeting held in 2011 and a Torrent Young Scholar Award and is recognized among the top 10 brains in India from between 2009 and 2010. Sir has also various research publications in Annals of Indian Academy of Neurology and academic experience as assistant professor in medicine and lecturer in biochemistry. We are delighted to have you on board, sir, as a moderator. Thank you so much for your valuable time. Next up, we have Dr. Jiten Anthony Bose as a speaker. Sir is a consultant neurologist and neuro-interventionist at the Rajagiri Institute of Neurosciences, Kochi. Sir has completed his European Diploma in Stroke Intervention, postdoctoral fellowship in Stroke and Neurointervention, DM Neurology from the Government Tanjavur Medical College. Sir has a high volume acute stroke specialist with extensive experience in mechanical thrombectomy and advanced endovascular stroke interventions. Sir has performed more than 400 acute stroke interventions and 130 plus middle meningeal artery embolization procedures for chronic subdural hematoma. Sir has an expertise in vascular neurology, including carotid strengthening and intracranial angioplasty. His key leadership roles include establishing Kerala's first NABH WSO accredited comprehensive stroke center and an FNB stroke medicine training program. Sir also has special interests include endovascular stroke therapy, MMA embolization, and development of comprehensive stroke systems of care. Thank you so much, sir, for your valuable time. The next speaker we have on board is Dr. Baishak Renuji. Sir is an assistant professor neurology at the Malankara Orthodox Syrian Church Medical College in Kolancheri. Sir has completed his DM neurology from the Government College of Trivandrum and is also the gold medalist in MD General Medicine from the Government College of Mysore. And also he has completed his MRCP SE in Neurology UK. Sir has more than 5 years of experience in tertiary care neurology with expertise in acute stroke care, neurocritical care, cognitive neurology, and also movement disorders. Sir has also been experienced in thrombolysis, emergency neurology, Parkinson's disease management, dementia care, and also multidisciplinary neurological management. Sir is the assistant professor in neurology with strong academic involvement and also the national faculty at the Marrow Super Speciality Program that includes mentoring MD, DM, TNB aspirants across India. Sir is also the gold medalist and the best outgoing student of the MD General Medicine 2014 batch with multiple peer-reviewed publications in Neurology India, Nepal Journal of Neurosciences, and JCDR. Sir is also an active researcher with publications in stroke, migraine, encephalopathy, headache disorders, and rare neurological presentations. We are glad to have you on board, sir. Thank you so much for your valuable time. With this, I would now like to hand over the session to Dr. Joseph to take it ahead.
Thank you, Kalpita. So we have a very eminent speakers with us today. As we all know that acute stroke management has become very interesting and has become more aggressive over the years. And we have two young aggressive stroke physicians here. So without wasting much time, I think we will start with the first speaker, Vaishak Renuji, and then after the first talk, we'll have a short discussion, and then we'll go for with the talk by Dr. Jitin, and then have a discussion. So Dr. Narayan Unni will moderate the further.
Okay, good evening. I'm a test player. I play test cricket, but we have two T20 players who are very aggressive from the outset. So we will listen to what the T20 players have to say. So I think Vaishak will presenting first. Okay, so we'll hand over the session to Dr. Vaishak. Over to you, Vaishak.
Thank you, sir. I'll present the case. Actually, we manage it combinedly with Jitin, the same case. I'll share the slide. Slide is visible now?
Yes.
Yes, sir.
So, this is a 70-year-old male who is a smoker. Known case of hypertension, COPD, and he has deranged RFT also. He had history of right lower limb weakness and imbalance while walking since last 2 days. Yeah, and he actually initially came to the casualty. He also has an interscapular pain that was present since last 1 to 2 months, and occasional numbness of the right hand, entire right hand, since last 1 to 2 months. And he was a smoker. He quit smoking almost 2 months back because of he had a recent respiratory infection at that time, and the cough was worsened, and so he was advised to stop smoking. He quit smoking. There is no history of any other findings like altered sensorium, loss of consciousness, clinical seizures, or any involuntary micturition, defecation, or vomiting. Upon examination, initially, his BP was 130/70. Higher mental functions and granulomas were normal. UM was full non-nystagmus. There was a right lower limb weakness, distal dominant, predominantly an ankle weakness. Dorsiflexion was 3/5, plantar flexion was 5/5. Right plantar was extensor, gait ataxia was present, also upper limb ataxia was also present. There was no significant weakness in the upper limb. So initially thought it is a hemiplegic distribution around one side, predominantly ataxia with subtle weakness predominant in the lower limb. So ataxia hemiplegia was initially considered, but there was no significant cranial nerve findings or dysarthria to localize it predominantly to a brainstem or cortex. So the likely localization can be above cervical spine above, because there is no cranial involvement, there is no dysarthria or any cortical signs to suggest, but it is only on one side. So hemi distribution, but one thing was he was having a 1 month history of back pain, upper back pain, upper thoracic pain. So this was MRI taken. It was showing multiple embolus. You can see on the left cerebellum, right cerebellum, then the right PCA, left PCA. You can see on the left MCA, PCA watershed, then the subcortical, then the internal watershed on left side, as well as on the right side ACA, MCA watershed area. There is multiple shower of embolus. Initial ECG was normal. There was no AF. And the screening echo was done from the ICU. Actually, the patient came to OPD directly. So from ICU, screening echo was done. It was also normal. There was no clot. So this pattern of involvement was something typical. This is known as 3 territory sign. When you have involvement of the bilateral cortex with anterior and posterior circulation, that is very, very suggestive of malignancy-related stroke. So actually, when he came in the OPD, as usual, I didn't examine for clubbing. I didn't examine general examination as usual. Like, because it is a stroke, I admitted directly in the OPD. Then I went and re-examined. This was a 3 territory sign, which is published in Neurology Journal in April 2019. And this is a bilateral anterior plus posterior, at least 2 territory. And the same finding actually can occur in AF also, because AF being the common etiology, that is most likely it was usually. But he being a smoker. So again, I went and examined. He had a right lower cervical node was there, 3 into 3 centimeter, firm inconsistency, and he had a clubbing. So usually in OPDs, in busy OPDs, we miss all those things. But when I saw the MRI, they went back and examined. I didn't see initially about clubbing. I didn't look for any notes in the beginning. That general examination part was incomplete from my side. Then checked at the X-ray. If you look into the X-ray, there was one is mediastinal widening. Is there is a spiculated area in the right side towards the mediastinum, and you can also see a spiculated lesion located in the right midzone of the X-ray. So in the background of smoker, the strong suspicion of malignancy with a triple 3 territory sign. So we went ahead with CT, but he had an RFT impairment. His creatinine was 2 point something, I remember. So we could not proceed with the contrast. And echo was normal, ECG was normal, and D-dimer was very highly elevated, more than 1000. And hemoglobin was 8.3, platelet was 2.5 lakhs. And his peripheral smear, I remember, was normal, normocytic, normochromic. Other findings, including PTANR, APT, bleeding pattern was initially normal. So we went with a plain CT. In the elevated D-dimer again suggests that a thrombosis secondary is happening somewhere. So we went with a plain CT because he was a smoker. And CT thorax again showed the same. There was a large lesion which encasing the right main bronchus, possibly a tumor which is extending to the upper lobe and compressing. There is a concomitant lesion. So suggestive of a lesion. So we could not go ahead with, we asked the pulmonology to take for any biopsy. Then we directly went with, started with single antibiotic, Cospirin 75, and heparin was started, physio and statin was started. He had improvement of the power improved in day 2. Then we had taken a direct biopsy, heparin was stopped, and biopsy was taken in the node, cervical node, excision biopsy was done. And post biopsy, he was fine. On, I think it was 2nd day of post biopsy, I taken the rounds and came back, he was fine. By 12 p.m., around 12 p.m., he suddenly developed word finding difficulty and right side weakness. Initial angio was also normal. I forgot to show that initial angio was normal. So this was the second MRI. Just taken, you can see that there is old infarct on the right side, but you can see an early diffusion restriction starting developing on the left insula. You can see diffusion restriction in the left insula. Then you can see in the high cortical in the M4, M5 area, also there was some diffusion restrictions developing. You can also see in the temporal, anterior temporal area also there was some diffusion restriction is evolving. And these changes was not fairly developed in the flare. So there's a diffusion flare mismatch. And obviously the MRI was taken somewhere around 1 o'clock or 1:30. So it was around 1.5 hours from the window. And this was an angiogram. In the angiogram, you can see that the left IC is fine, but you come here, the left MCA, distal M2. Behind that, there is flow is not that visualized. There is a thrombotic occlusion happened there. So he already had an elevated D-dimer. He already had a malignancy. In the background of malignancy, it is high risk to lyse at such a situation. And I didn't have any values of platelet or it was done actually prior to the surgery. Surgery was done 3 days back. That value was normal with the HP of 8.3, platelet was 2.5 lakhs. And our neuro radiologist was on leave. So I had referred the patient to, I had called Jidin and referred the patient to Jidin itself. In Rajagiri, they actually, the bystanders were very aggressive. We had talked to them, well, from here also, because it is a malignancy, doing such a high risk procedure may not be beneficial. And their bystander, one person is from UK, and he was telling that we are ready to accept the risk because we want our father to be healthy as much as time he lives, rather than letting him do in a bed. So with that consent, we shifted him to Rajagiri, and there Jidin did a thrombectomy. Then Jidin was telling when he was doing the thrombectomy, it was very difficult to stop the bleed from the puncture site. Later, he had a low platelet, hemoglobin was dropped, elevated FTP, low fibrinogen, bleeding parameters are deranged. He developed frank DAC. And then he had a reperfusion bleed also, but bleed in the brain was not too large. Then from there, they did a medical board and they consulted the oncologist. As a DAC is there, DAC is possibly secondary to malignancy. Very unlikely to have a DAC improvement when it is the primary etiologies remain untreated. So primary etiology being malignancy, which is very difficult to treat because we don't know what malignancy it is, because the biopsy report, it was not available. We don't know what was there in the biopsy. Then patient had referred back to our hospital. He came back to our hospital. Then the biopsy came as again a tumor emboli. Was diagnosed with the biopsy came as possible metastatic adenocarcinoma of pulmonary origin from the lymph node. Then later we had discussed the bystanders and the family, and we have explained them when once there is a solid malignancy with DAC, the survival rate is very poor, probably weeks to months. And one DD was apparent disc thrombocytopenia, but apparent disc thrombocytopenia usually FDP won't be elevated, fibrinogen won't be low. So this was again, there was not just a platelet, there was drop of hemoglobin, but there was no massive visible bleed anywhere. So we discussed the bystander. They told that further they don't want to aggravate the treatment because the survival rate is that much. They actually wanted to give a try whether he will improve. If he improves, they want him to have a good life. So right now, as the patient is having a poor prognosis, they given us no further aggressive treatment, and later the patient succumbed to death. The story is not about the outcome of the patient, but about the rarity of the entity. So this is a 3 territory sign where you can see the bilateral anterior and posterior circulation, acute ischemia is there at least 2 locations. And the common thing is actually the AF. But you can see that when the number of lesion and territory is 1, the probability of AF is much high. If it is 3, the probability of malignancy is much high. It is almost 6-fold higher than AF. So this was an eye-opener for me that even in OPD, if it is busy, you have to do general examination and see chest X-ray properly even in the stroke. And this is another case report, similar finding. This came in 2019. And there is another mechanism which is like, this is actually non-mechanism. It is thought to be 2 processes were supposed to be happen. One is metastatic deposit in the heart, or the second is a thrombotic event like torso syndrome, like because of the increased thrombosis secondary to malignancy. So this patient developed into DAC and all that itself tells that it is because of the malignancy producing DAC. Thank you, sir.
That was a very wonderful case. The way it started, you were saying there is some interscapular pain and crural weakness and some sensory symptoms in the upper limbs. I was thinking of a aortic dissection.
Yeah,
so
sorry,
whenever
when
there is chest pain and crural weakness, always this possibility of an aortic dissection needs to be considered. So I was thinking of an aortic dissection, but then it turned track. And I think that MRI is very much very crucial. If that whenever we see a triple territory sign, always need to think of a malignancy first, and only cardioembolic comes second, as you have rightly mentioned. And we have been, all of us have been picking up more and more of this MRI findings, and then leading on to a malignancy. I think it's very much there, this triple territory sign. And regarding the intervention thing, I think it's always good to have a bystander who allows you to express yourself. I think that is probably one reason why you referred the patient, because if the vice chancellor wants the intervention to be done, I think there are nothing that is going to stop you. And I think as we all know, the situation in DIC is always the prognosis is very poor, because there is a disseminated coagulopathy, which can result in thrombotic and hemorrhagic episodes. So I think that was a very wonderful case. Any comments from Joseph, sir?
Yeah, that case was very interesting, and I found that the family was very bold enough to proceed and do an aggressive treatment. And I think I think what was they could open the vessel where Jithin?
Yeah, sir. Actually, it was a distal M1 occlusion. The vessel was actually open. Distal M1 with M2. Actually, he had distal M1 with both bifurcation occlusion. So it was open. Both vessels were actually open, but the procedure actually was over in 20 minutes. But post procedure, actually, when I removed the sheath, I had to actually compress the site for around 2.5 hours, because the DIC wasn't there when the patient was, referred, because it was already setting in. So that is when actually I came to identify this DIC, and then his fibrinogen was very low.
And when you do the procedure, will you able to differentiate, because that clot, does it came as tumor emboli, or it was no clot at all after the procedure?
It came as an emboli, sir. Actually, that histopathology also was done. I didn't get the report actually. The report also is some embolic particles. This it was actually a tumor emboli like thing. It was not actually this fibrin and the RBC rich clot actually. It was a whitish kind of thing, not the routine.
Okay.
So this was more of a MEVO, is it? Not a LVO.
Yeah, it was actually a MEVO, sir. Actually, this guy had actually, I remember he had only grade 0 power when he came here. He was having gaze preference grade 0 when he came to this hospital. I don't have the pictures now.
Even when I was referring, also he had grade 0 power gaze
Yeah.
And I think now there are more and more research coming out regarding efficacy of thrombectomy in MEVO also, is it not?
Yeah, dominant MEVO, actually they are putting for the theory of thrombectomy in dominant artery MEVOs.
They are telling dominant is not the left side. They're telling it is the dominant flow, like 50% supply MC.
Yeah.
Right side, if it is 50% supplied by the same vessel, you can open it.
Yeah.
Okay, so on that note, I think we'll move to the second case, Dr. Jithan.
Yeah.
Is my screen visible?
Yes.
Okay. So this is the story of a 30-year-old female. She was admitted in general medicine with a fever for 3 weeks. So she was getting treatment from the medicine department. Suddenly she developed a weakness with a dysarthria and a facial weakness. The NIHS score was 7. It was recognized to be a stroke. The power in the upper limb and lower limb was 3/5. So we did an MRI. I will tell the specific reason why I went ahead with an MRI. So MRI was completed maybe within a 20 minutes time. So this was the diffusion, ADC, and flare sequence. As you can see, there's a diffusion restriction with a corresponding ADC, and there was no flare change. It was done fairly early, into 20-30 minutes of stroke. So this was angiogram. The left MCA was non-visualized, or it was faintly visualized with the extracranial carotids and other vessels were normal. So when you see the back end of the story, actually this patient was admitted with fever and with some findings of infective endocarditis. She had the splinter hemorrhages, Osler's knots, and an echocardiogram was done by the cardiology team. She had an aortic regurgitation with a vegetation of 1.3 into 0.6 centimeters. And her blood cultures was positive for Enterococcus fecalis. And she was getting ampicillin and gentamicin. She was into treatment for around 10 days or 12 days. And she was in the hospital. That is why it was done very fast. And she already had a history of both hands were having emboli to both hands. And so I couldn't go ahead with the CT angiogram. That's why I went ahead with the MR angiogram. Both hands were actually wrapped and were getting dressed for that. So this patient is a patient with infective endocarditis in window period. So what to do next? That was the question. So should you go ahead only with antiplatelets? Should you thrombolize her, or should you do only mechanical thrombectomy, or should you go ahead with thrombolysis or mechanical thrombectomy? So according to the new guidelines and as well as with the old guidelines, patients with ischemic stroke and infective endocarditis symptoms, IV thrombolysis is contraindicated. So this was her echo. So this echo was showing severe AR with the vegetation attached to the aortic valve, which was around the size of 1.3 into 0.6 centimeters. So we planned and went ahead with the mechanical thrombectomy. Mechanical thrombectomy in infective endocarditis patients is very challenging because although the recanalization rates are technically similar to a non-infective endocarditis stroke, the functional outcomes are often lower because of the systemic disease. However, that is the only viable reperfusion strategy in a patient with infective endocarditis and a large vessel occlusion. So that was the only option for her and for us. So she was taken to the cath lab. This is a normal angiogram I have put on the right side of the screen, and this is the patient's angiogram. As you can see, there is a occlusion of the left proximal as well as the entire MCA. I'll mark and show you the images. So this is the CCA angiogram. This is an AP view. I have marked the ACA and the ICA. You are not seeing the MCA, but you can see some pile collaterals filling from the ACA to the MCA territory, some retrograde filling of the MCA. So this is the CCA angiogram, the lateral view. You can see a large void area or an infarct or a penumbra area. So she's only 30 years. And so we planned and went ahead with the mechanical thrombectomy. Thrombectomy was done using the Solumbra technique, that is using a stent retriever and an aspiration catheter. With a thrombectomy, the vessel was opened, the flow was restored with some residual spasm of the vessels, but the flow was good enough. This is a lateral view. So this was the material that was retrieved from the stent retriever. This was also a whitish kind of material. And we send them all the thrombectomy specimens, we send it for histopathology. So this was also sent for histopathology. So this histopathology was compatible with organized thrombus with a few gram-positive cocci. So this was actually a thrombus with a few gram-positive cocci. Her power improved to 5. She had only mild facial paralysis after that. So this was a post-mechanical thrombectomy MRI, only subtle flare changes. So the etiology was an infective endocarditis from a dental caries infection. So the route of emboli from bloodstream to the brain. So in view of recurrent embolic events, because she had an embolus to the palmar arch 1 week ago, which was managed conservatively, in view of the recurrent embolic events, the cardiothoracic team planned a surgery for her on the 12th day after stroke. Usually, infective endocarditis with an acute event, they usually don't get surgery in an acute setting. But for her, this was a friable tissue. It was getting embolized recurrently. And in another scenario, if there is a prosthetic valve endocarditis also, the cardiothoracic team can take the patient for an acute setting surgery. So this lady had a friable tissue which was getting embolized multiple times. So she was taken up for surgery. So surgery was done, aortic valve replacement was done. There was no fresh stroke. So this was a post valve replacement surgery echocardiogram. There was a normal functioning aortic processes in situ. Status post aortic valve replacement. So I'll just put a brief comparison of the infective endocarditis related versus the non-infective endocarditis related stroke outcomes. As you can see, the mortality and symptomatic ICH after thrombectomy are significantly higher in infective endocarditis related strokes. The recanalization rates are almost similar to the non-infective endocarditis strokes, and the favorable outcomes are significantly lower in patients with infective endocarditis related strokes, especially undergoing thrombectomies and other procedures. So what patient you have to think of stroke risk in an infective endocarditis? Patients who have Staph aureus infection, a vegetation of size more than 10 millimeters, people with high intensity signals on transcranial Doppler indicating embolic signals, hypertension, atrial fibrillation, and hyperlipidemia. These patients are having high risk for stroke in infective endocarditis. So what are the risk factors for ICH in those patients? People with thrombocytopenia, stroke patients previously, or an intracranial hemorrhage previously, increased number of cerebral microbleeds, or obviously mycotic aneurysms in infective endocarditis. Is there a simple blood marker where we can quantitate these events? The simplest one is a mean platelet volume. The usual value is around 7.5 to 11.5 femtoliters. When the MPV starts to increase, that means there is a platelet size is getting higher. The platelet is getting activated. The platelet function is going high. So higher MPV means increased platelet activation and higher embolic risk. When patients are getting admitted for infective endocarditis treatment, a simple measurement of the MPV across can predict actually a embolic event risk. Is there a routine antithrombotic therapy required in infective endocarditis patient? The answer is no. Do not initiate antiplatelet or anticoagulate therapy routinely. It is not solely required for stroke prevention in a newly diagnosed infective endocarditis patient. So what are the mechanical thrombectomy related problems in LVO in infective endocarditis patients? These often require multidisciplinary discussions because they have a higher risk of complications. You have to weigh the hemorrhagic risk and vessel friability because most often they carry high hemorrhagic risk and reperfusion bleeds. Although they have similar recanalization and 3 months outcome, the risk of complications are much higher. And of course, IV thrombolysis is having much more complications for ICH. MT is the only safer option reperfusion strategy in selected infective endocarditis related large vessel occlusion patients. So when to do cardiac surgery after stroke in infective endocarditis? In patients with TIA or a silent emboli, early surgery is reasonable. This patient had an ischemic stroke. She did not have any hemorrhagic transformation. We did a surgery after 11 days. She underwent a surgery on the 12th day. A hemorrhagic stroke, if you have a patient with hemorrhagic stroke and infected endocarditis, delay the surgery for at least 3 to 4 weeks. Severe neurological deficit patients, you have to defer until the improvement is evident. And all the meta-analysis findings suggest that early surgery will improve the periop. Early surgery increases the periop mortality and neurological complications. Benefits seen with the delayed surgery, especially after a hemorrhagic stroke. Thank you.
Oh, Jidin, that was an excellent case, a very interesting case. and the timely intervention at the right time, I think that saved the patient. And I think the what all the various things that can be done for the patient was done. No. And she went home perfect.
Yeah, sir. Her MRS is 0. She still comes for follow-up.
Okay. Very good.
Was the bug grown in the blood? Was the blood culture positive?
Yeah, sir. Blood culture was positive. She was getting treated for infective endocarditis. She had a dental caries actually. So it came.
What is interesting or what is more worrying is the patient was already on IV antibiotics for 2 weeks, isn't it?
Yeah.
And
Yeah.
despite that, she developed an embolus.
Yeah.
And one experience that I have is the cardiologists are not always very confident of making diagnosis of these vegetations on the valves. Whenever we refer to rule out vegetation, mostly they say there is possibility of a vegetation. Most of the time it's like that. So I feel blood culture is the most unless it is so evident as it is in this echo. And was this echo done after the stroke or was it?
No.
It was already. It was done before, right?
It was there before, sir.
Okay. So the 2 weeks of treatment and still developing a stroke, that was something very interesting. And she was treated with the usual antibiotics only, right? The ceftriaxone.
She was treated with culture-sensitive antibiotics, sir. I think some ampicillin or gentamicin. She was having Enterococcus faecalis that was positive for ambigenda. Then she was getting treated with that actually.
How good is a cardiac MRI to make a diagnosis of endocarditis?
I think,
because, as I said, echo sometimes can be very misleading. Even the cardiologist is not very sure.
Sir, maybe this 2023, this ISCVD criteria, I think this Duke's criteria they have modified, and they have put so many imaging parameters into that criteria. Previously, only this the routine things and the blood culture was there. Now they have put a lot of imaging markers also into that.
Okay.
I mean, even PET also is there. I don't know for sure, but it's there, I think.
It was nice revisiting this oscillatory nodes and all those splinter hemorrhages, which we have learned in our Hutchison. And to see that after so many years, it was really interesting. It was such a wonderful case. Both of them was very nice. Joseph, sir?
Yeah, both the cases were very interesting and was more of a general medicine case. And we had two emboli. One was a tumor emboli, and another was a septic emboli.
Septic.
Yeah. So it was. I think. So I think we have to have our general medicine eyes also very active when you see these patients. One other patient had clubbing and all, and this patient had splinter hemorrhages. And both underwent mechanical thrombectomy, and the second patient had a very good outcome.
Yeah. So thank you both the speakers for those wonderful cases. And shall we hand over to the organizers?
Yes, sir. Yes, sir. Good evening, all. And it was a wonderful case presentation and discussion on the Saturday evening. It was really, and on behalf of the team Gennova, we would like to extend the heartfelt thanks to our respected Dr. Joseph, for being the course coordinator for today's KT Live, and also conveying our thanks to moderator Dr. Narayan Unni. Also, we would like to express our deepest sense of gratitude for Dr. Baishak and Dr. Jatin for being the speakers for this program. We are all sure that all the delegates would have immediately and immensely benefited by the wisdom shared by eminent faculty. Thank you, sir. Thank you for such a wonderful weekend with the science closing. Thank you, sir.
Thank you.
Also, to add on, we are very delighted to be, or I think, taking this platform to announce one more interesting thing that will be coming up. So we are soon in the process of launching a dedicated application and app for this webinar, which is the no thrombosis. So all our sessions which keep happening, we'll be developing an app so that it becomes like a scientific repository for our audience to go back and check the cases. So soon we'll be reaching out to each and every one of you for your consent for the same. And with that said, we'll be launching our app very soon. So we look forward to have your key insights in that application and making it accessible to more and more doctors going forward. So thank you so much for this opportunity given to us.
So thank you. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you. So should we leave?
Thank you and good night.
Yes,
Okay.
sir. Thank
Good
you.
night. Good night.
Good night.